I'd like to thank the scientific community for the scientific committee for inviting me to present. It's always nice to come back home. So when we talk about complications of endovascular aneurysm repair, endoleak is the vast majority of all complications that we have to deal with, particularly in the long-term follow-up. The majority of these patients have type 2 endoleaks, and so I'm not necessarily sure I would consider it a complication unless they enlarge. If you have a type 1 or type 3, that mandates correction, or if you have an enlarging or persistent sac with persistent type 2 endoleak, that mandates further investigation. So I'm going to focus the talk today on long-term follow-up and management of type 2 endoleaks. So I think this is what people deal with the most. Just to get a sense of the scope of the problem, this is from the OVER trial, which was a randomized control trial comparing open and endovascular repair. They looked at all the endovascular patients and looked at the spectrum of their endoleaks. And as in most reports, about 75% of the endoleaks were type 2s. Over the 6-year follow-up, 30% of patients developed an endoleak. And a little bit over half resolved spontaneously. About 30% received secondary interventions because of their endoleak. And what they did find was that the initial aneurysm size was predictive of the need for a secondary intervention. And if you show up with a delayed type 2, that was associated with aneurysm enlargement. And so how do we work these patients up? I mean, we all follow our patients with CT scan. Ultrasound is very sensitive for picking these up. MRA is probably the most sensitive, but you really want to characterize the direction of flow and the type of endoleak. And so you want a dynamic study for that, such as a cine-MRA, angiography, or even duplex. You can sometimes tell the direction of flow because that will determine your therapy. I'll go quickly through this. Some of the pitfalls of CT scanning. You want to make sure you get a non-contrast CT to be able to differentiate between calcification in the sac and an endoleak. You also want to make sure you get delayed phase because that will increase your sensitivity. You may not see an endoleak on arterial phase, but on delayed phase it becomes more obvious. I like MRA in difficult to diagnose cases with a MR compatible device because it's sensitive, it can give a direction of flow, it mimics a diagnostic angiography and allows you to plan for your intervention. And there is some data to say that it may be more sensitive than CT because you can follow out for much more prolonged imaging. And so in a slow-flowing endoleak, a case that might be read as endotension on a CT scan, you can often identify the endoleak on MRI. You do have to keep in mind that you cannot do it in stainless steel-based devices, such as the Zenith. And if you have stainless steel coils in the sac as well, you'll get a lot of bloom artifact, and so you won't be able to interpret the MRA meaningfully. I'll go quickly through this. So as far as the treatment, you really want to consider a type 2 endoleak like an AVM. So there are multiple side branches that lead to the endoleak cavity, and there are multiple side branches that lead out of the endoleak cavity. And so if you just get one or two, you'll still have perfusion in the sac and persistent endoleak. And so you really want to get the whole nidus as well as many of the inflow and outflow branches as you can. There are multiple access options. And there are multiple embolic agents. And so I'll first focus on the access options. Probably the most common that we do is transfemoral embolization, so either through the SMA or through the hypogastric, getting into a side branch. And so here's an example of a microcatheter through the marginal artery into the inferior mesenteric. You can see the sac filling and outflow. And you really want to get into the nidus, embolize the outflow branches, and then on the way out, embolize the IMA as well to get a satisfactory result. There are cases where a transfemoral approach is not feasible. If the IMA is occluded, if you have very tortuous collaterals between the inferior epigastric, the internal iliac and the lumbars, you may not be able to traverse it with a microcatheter. And so you want to consider alternative access in those cases. Translumbar embolization was probably described before transcaval, but you access through the back under fluoroscopy or CT guidance until you get blood flow return, and then you can embolize with all the typical embolic agents we use. The patient's typically either in the lateral or the prone position. And favorable anatomy is where you can see the sac is typically towards the left side. The nidus of the embolus is towards the left side. What we've gone to in our center is we've embraced transcaval embolization because we found it a little bit easier to do in terms of the patient positioning. You go with a Roshishita set through the vein, through the cava, and it's especially favorable if you can see that the nidus of the sac is towards the patient's right, and there is the IVC and aorta are coapting each other. We like to use DynaCT for these cases, and so you can superimpose the location of the nidus onto the patient, and you can give yourself a little target You can see here with our Roche set, the circle is on the access point, and then that sort of squiggly line is on the nidus itself. You puncture, you get in, and you image, and you see the outflow vessels, and then you treat it just like you would for transfemoral. It's actually surprisingly easy, and so people who've tried this become fans of it once they've done it once or twice. The key is not to embolize into thrombus. You really want to get into the sac and see outflow via branch. You'll often have to put multiple coils, and I like to use onyx sometimes to get the final outflow. My partner who did this case used a little bit of thrombin, and then you'll pull back. You can image. You see that there's the cave is patent, and the patients generally tolerate it. You can do it under light sedation, and they're supine, so they can take the time to do this. I will skip quickly to just some of the liquid embolic agents in the time remaining. Most of us should be familiar with coils, but sometimes in more complex interventions, when you can't track a coil out, a liquid embolic agent may be useful. Glue is very easy to deliver. The main issue is non-target embolization, and there's a possibility of gluing the catheter in place. It is MR compatible. It does put a little bit of artifact on CT scan, and so again, for follow-up, it may be easier to follow these patients and rule out an endoleak with an MRI or a duplex. Onyx is another liquid embolic agent that we use, and it's a little bit safer than glue, I find, because there's less risk of non-target embolization. You can inject it over a longer period of time, and it allows for good nidal penetration. So sometimes we'll use a combination of onyx and coils, and this allows you to get out into the outflow vessel, but you don't have to worry as much about the spinal cord embolization. You do need a DMSO-compatible catheter, and there is more radiation with this approach. And I think one final thing as far as follow-up, on CTA, you'll often get a non-contrast post-image to see if the onyx makes a cast of the vessel.
Your time is up.
And so just in conclusion, I'll jump to the last slide. Sure, even 30 seconds. I think when you're dealing with type 2 endoleaks, the main thing is to have a good sense of what the underlying problem is, and so appropriate can I go just to my last slide? Appropriate preoperative imaging with dynamic imaging to allow you to determine where the endoleak is coming from, and then you have a number of access options to allow for effective treatment. And I guess I'll end it there. Okay, well, thank you very much.